Thank you for joining this webinar. What does the direct protocol mean and how does it impact meaningful use stage 2 implementation? We appreciate you joining this, and I'd like to introduce our facilitator. Before I do that, I'd like to mention if anyone has any questions during this webinar, please click on the questions button on the lower right portion of your screen and enter questions, and we will go over as many of those questions as we can at the end of this session. So I'd like to introduce Lee Barrett, who is the Executive Director of EHNAC, a federally recognized standards development organization designed to improve transactional quality, operational efficiency, and data security in healthcare. Previously, Lee was President, CEO of IGI Global Health, a provider of services to HIEs, EMRs, portals, and EDI transactional platforming. Mr. Barrett has 10 years leading healthcare professional services organizations, including PricewaterhouseCoopers, SAIC, Covantis, and Virtusa. He has 20 years in senior management roles in payer organizations, including Mass Mutual, Connecticut Mutual, Travelers, and Aetna. He has also been in senior leadership for the American Dental Association Business Enterprises Incorporated, a for-profit wholly owned subsidiary of the ADA, a provider organization. He has served as chairman of WEDI and the ASCII X12N Insurance Subcommittee and has been on a number of other industry board roles. He speaks nationally on a variety of e-health, e-commerce, and industry topics and is involved in a number of industry coalitions promoting the use and implementation of both administrative and clinical transactions, including the development and proliferation of EHR and meaningful use, including the National Health Information Network, health information exchanges. Mr. Barrett continues to work on key e-health industry initiatives that lay the foundation for health information technology, including support and implementation of the American Reinvestment and Recovery Act, Health Insurance Portability and Accountability Act, and the Health Information Technology for Economic and Clinical Act, better known as HITECH. So I welcome Lee, and Lee, I'll turn it over to you.
Thank you, Ron, and hello everyone, and welcome to our webinar today. We've got a terrific panel to go through and provide you with really, I think, a terrific perspective on the direct protocol and talk about many of the issues having to do with direct and meaningful use stage 2 implementation and its role in it. So without further ado, I'm going to go through and introduce our panel. And our first panelist is going to be Claudia Williams, who is Director of the State Health Information Exchange Program in the Health and Human Services Office of the National Coordinator for Health IT. She leads ONC's efforts to enable health information exchange to support provider achievement of meaningful use and sustainable improvements in health and healthcare efficiency. In addition to her role at ONC, she also serves as the Health IT lead for the White House Chief Technology Officer. She came to ONC from the Marco Foundation, where she was Director of Health Policy and Public Affairs, and helped direct the Marco Connecting for Health, which is a coalition of healthcare leaders from across the spectrum of perspectives, including technology innovators, leading provider groups, and consumer organizations who advance recommendations for using health IT to make rapid improvements in healthcare system performance. Prior to joining Marco, she also directed the Synthesis Project for the Robert Wood Johnson Foundation, which is an initiative to inform key coverage, health market, public health, and care delivery policy decisions and strong research evidence. She's also held senior positions at the Lewin Group and in the Office of the Assistant Secretary of Planning and Evaluation at HHS. She holds an MS in Health Policy from Harvard School of Public Health and a BA from Duke University. Our next presenter is Dr. David Kibbe, who is a senior advisor to the American Academy of Family Physicians, where he speaks annually at the National Conference, and in his previous role as chair of ASTM on informatics, in his current role as president and CEO of Direct Trust. He is known as an innovator and an independent thought leader in the fields of EHR, PHR technology, health IT standards, and participatory medicine in the United States. His writings have had strong influence on the modular approach to EHRs, the development of clinical groupware, and the use of internet for direct compliant clinical messaging. He's a co-developer of the ASTM Continuity of Care Record Standard, or CCR, that utilizes the XML for computable health information exchange. And he is also an experienced clinician who has practiced medicine in private and academic settings for more than 15 years. He's taught informatics at the School of Public Health at the University of North Carolina at Chapel Hill and founded 2 healthcare IT companies. From 2002 to 2006, he was the founding director of the Center for the Health Information Technology for the American Academy of Family Physicians, which is a membership organization that represents over 95,000 U.S. family physicians. He also maintains his relationship on a part-time basis with the American Academy as a senior advisor and is a blogger on health IT policy and provides strategic policy and IT consulting to a wide variety of health IT firms and institutions. He's also a frequent speaker on health IT trends and innovations, and especially on the topics of meaningful use, health IT in the patient-centered medical home, and physician-patient information sharing. Next speaker is Andy Harin, who's director of the Cerner Network IP. He's responsible for aligning market needs with current capabilities for the Cerner Network, a foundational component of a system which facilitates the coordination of care, incentives, and commerce across consumers, providers, and payers. He's one of the founding board members for Direct Trust and currently serves as chair for the Security and Trust Compliance Work Group for that organization. Don Jorgensen is CEO of Impriva, where he has more than 30 years of experience leading embedded system and software development projects in energy management, telecom, and healthcare. Over the past 10 years, his focus has been on healthcare information system interoperability, security, and privacy. Don has been involved with the Direct project from its inception and currently serves as co-chair of the Direct Trust Certification Policy and Practices Work Group and is on the Direct Trust Steering Committee. He's also co-chair of the HL7 SOA Work Group and serves as lead of the HL7 Privacy, Access, and Security Services Project. He's also been active in IHE, HITSP, and NHIN standards specification initiatives as well. Ron Moser, who is Managing Director for Moser House Consulting and a Senior Reviewer for EHNAC, has 28 years of professional information technology experience. 25 of those have been specifically focused in healthcare IT. As a Managing Director for Moser House Consulting, he provides guidance to organizations committed to improving their operations through the implementation of effective risk-based IT controls. He specializes in the areas of healthcare IT and accreditation through EHNAC and has led many organizations through the EHNAC accreditation process as a site auditor and reviewer. In addition to direct consultative work with these organizations, he also has provided leadership and development of many of the EHNAC programs and developed many industry white papers through the coordination of advisory committees of industry experts. In his role as a site reviewer, he has performed audits for many different types and sizes of organizations over the past 7 years. He has extensive knowledge of HIPAA high-tech and of all of the EHNAC programs. Prior to forming his own company, he was Director of Clearinghouse Operations for NGC Health, and he has extensive experience advising and working at all levels of organizations from the C-level to technical individuals. He has a strong background in management, software design and development, and IT controls, framework development, and has led the publication of healthcare industry white papers. He holds a Certified Information Systems Auditor certification and is also certified in Risk and Information Systems Control. He's a Bachelor of Science in Computer Science from Taylor University. So that's our panel for today, which really I'm very excited and hopefully will give us some tremendous perspective on a variety of different aspects of the topic that we're going to talk about today. Next slide, Ron. So let me talk about our webinar objectives and what we're going to look to share with you today. First, we're going to talk about really the how organizations can assure HIS to HIS on interoperability and scalable trust. We want to talk about the various differences between EHR technology software certification and security trust accreditation for HISP certificate authorities as well as registration authorities who partner with electronic health record organizations. We'll also talk about some of the best practices examples, and you're going to hear from two of the organizations that participated in the beta that we went through with the Direct Trust accreditation program that we developed. And I think that will provide some very excellent examples for you that you can take back to your own organizations as you're evaluating what you need to do to meet compliance and hopefully to as well go through and apply for accreditation. Next slide, Ron. We're also going to talk about some of the aspects of reducing PHI exposure. So the aspect of privacy, security, confidentiality is obviously very critical here when we're talking about trust bundles and authentication. And so I think you're going to hear a lot about some of the risk management aspects that organizations need to go through, and also talk about what you and your organizations need to do to prepare to go through an accreditation and to meet some of the meaningful use requirements from ONC. Next slide, Ron. So we'll also talk about some of the challenges, therefore, that the industry is facing about really understanding the role of the direct protocol and assuring secure messaging, authenticating the trust anchors across all of the various stakeholders, determining and assuring stakeholder trust, which is absolutely critical, managing risk and risk mitigation, especially around privacy, security, and confidentiality. So those are the objectives and some of the challenges that the industry is facing. And hopefully you're going to hear from a number of our panelists that will look to address many of these issues. So let me turn this over to Claudia Williams, and Claudia's going to be talking about the ONC's role in promulgating direct protocol and the exemplar awards, as well as the plan forward that they're outlining for the industry. Claudia.
Great. Thank you so much, and it's great to be on the phone today with all of you. I look forward to a fabulous discussion and hearing from my colleagues as well. So really I want to situate the work with direct trust and on direct in two important contexts. One, meaningful use stage 2, and the other, the activities of ONC and our partners to advance the governance of health information exchange. So our overarching exchange goal and what we're really pursuing in our programmatic work, our policymaking, regulatory work, and in convening is that information follows the patient wherever and whenever it's needed, and most importantly across organizational, vendor, and geographic boundaries. And what we've seen in a lot of exchange activity across the nation is the difficulty of avoiding silos, whether those silos are EHRs or communities or even states. So the governance goals that we've set forward over the last couple of years are really to focus on three key things. One, to increase interoperability. Two, to increase trust among all participants, including the public. And three, and importantly, to decrease the cost and complexity of exchange. So if we've come up with a perfect way to allow for exchange that everybody trusts, but it's completely unfeasible from an implementation standpoint, we failed. We need a joint solution to all three of these problems. So over the last couple of years, we've developed a proposal to put forward a governance approach that would be in regulation, that would provide for voluntary accreditation against interoperability, business rules, and privacy rules. And we put out an RFI in 2012 of last year proposing what this approach could look like, that it would accelerate exchange by providing kind of a trusted seal of approval around certain requirements. And what we heard back resoundingly from many of you was that this domain of work was critically important, but that given the work, including of many of the people on the phone today, of existing governance entities, that rather than start something new, it would be far more effective to lend our weight, to lend our momentum to the existing activities that are already going on. And so we've put forward a series of important initiatives. So we have put forward 4 areas of activity in our non-regulatory approach, and 2 of those will be highlighted in today's conversation. The cooperative agreements, which are the work that we have going on right now with Direct Trust and also with the New York eHealth Collaborative, and also putting forward specific guidelines for implementers to support exchange. And the ones we'll be talking about today were released last week, direct implementation guidelines for assuring security and trust. So I really want to spend a few minutes talking about these guidelines because they'll link in an important way to the activities of Direct Trust that we'll hear about in a little bit. So in Meaningful Use Stage 2, so I'm on the slide that says Meaningful Use Stage 2 Transitions of Care, there are 3 exchange requirements. And the second requirement is the one that really drives forward electronic exchange, along with the third, in the most compelling way. And it requires that when a provider refers a patient, discharges a patient, or otherwise there's a transition of care, that along with that referral goes the patient's electronic information. And this needs to happen for more than 10% of the transitions of care and referrals using certified electronic health record technology. So let's dig in a little bit to what that Measure 2 looks like. So there are 2 options. The provider can either transmit using their certified technology, or they can participate in the eHealth exchange, formerly the NWHIN exchange. Now remember, either way, the requirement is that a referral occurs. Provider A sends to provider B picks up the information and uses it, whether that's through eHealth exchange and a query mechanism or through certified technology. So we're going to focus over here on the right in terms of the technology, specifically on the requirement that for CEHRT, the universal exchange mechanism that every certified system that needs to include is that of direct, is being able to send a direct message from one place to another. So there are other transmission mechanisms built into that are optional built into the technology, but the thing that will be universally available is the availability of the direct protocol. Now remember that the direct protocol was a community-developed initiative using existing standards, using SMTP and other existing standards, that went through a very public and very open process that many of you probably participated in to come up with a way to do a simple send, a simple push, that would be scalable and that would be easy to use. So we now see this standard being built into the regulations that are in effect right now, but really the work on the direct protocol over the last couple years has been profoundly from the bottom up. And now we're at the point where this can be the scalable mechanism for exchange for the nation. So last week we put out a set of guidelines, and I just want to spend some time describing what they are and why we decided they were important. What we were noticing is that in their implementations, a lot of the vendors and a lot of the implementations were essentially creating silos of interoperability where a participant could send to somebody else in that same system, but weren't able to send to another HISP or another vendor. And the reason for that is in addition to the technology itself, in addition to the actual protocol, there's a need to acknowledge and trust the sender and the receiver, and that's demonstrated by exchanging root certificates or public keys. And the policies that people had implemented and the procedures they'd implemented for deciding when and where you would exchange public keys varied. So in many cases, we were seeing vendors going out and having to really negotiate agreements one by one with each other so that there could be an exchange of public keys, so that there could be a use of direct across vendors. So the purpose of these guidelines is to help implementers overcome the policy and implementation differences that have limited cross-vendor and cross-community exchange. So we can really imagine direct being a universal exchange mechanism for stage 2. These were not requirements that are built into certification. They're requirements that have to be adopted by HISP And I think we'll be hearing from Direct Trust about the exciting ways in which this is then, these same requirements are being built into the accreditation program that they're developing. So what do the guidelines address? So they result from a consensus policy process that started with the State Health Information Exchange Program, but culminated in a meeting last November where the community itself said, what can we all agree to? And the guidelines represent what folks felt they could agree to as the minimum and necessary set of policies and requirements. And they include that every end user would be ID proofed before they are given a direct address. Remember that certificates in direct aren't used for establishing identity, but it's still super important that we know there's been an identity proofing process for every user. Also that folks would use FBCA basic or equivalent policies for certificate issuance. And in addition, that people would implement the guidelines that we've developed for exchanging trust bundles across the community. So what we're really aiming for is a common set of policies and mechanisms for exchanging trust bundles that are then built into an accreditation process that will actually mean that if I'm using certified electronic health record technology and my vendor is participating in this process, I would be able to send to anyone else who's also participating in the Meaningful Use program. That is our goal. So what should you do if you're a vendor? What should you do if you're an implementer? What should you do if you're in the community? What we are asking for people to do is follow the policies and implementation guidelines that have been released last week. We're asking that folks also get accredited by Direct Trust and add your trust anchor to its trust bundle, again, to ensure that we have a scalable way of supporting vendor-to-vendor exchange. But also we want you to continue to participate in the direct community so that we can collectively solve problems that come up in the course of implementation. And if you are a provider or using direct to exchange with other provider, ask your vendor or service provider to adopt the guidelines and participate in Direct Trust. Being able to accelerate the adoption of these policies is really critically important to support the success of Stage 2, and we remain incredibly, of course, committed to that. So I'm going to end there, and I'm really happy to take any questions as they come up during the discussion. Thanks a lot.
Thank you, Claudia. So our next presenter is Dr. David Kibbe, and David's going to be talking about an overview of Direct Trust and defining the need really for accreditation. David, let me turn it over to you.
Thanks, Lee, and thanks, Claudia, for doing such a good job of summarizing what this is all about and why it's so important that we succeed in making Direct Trust a universal, directed exchange a universal means of communication between providers and other providers and patients. We'll go to the next slide. And how about the next one? So I'm going to actually be fairly brief today because the speakers who come after me represent organizations that are actually doing HISPs, are actually making it possible for direct exchange to occur. What I think it's most important for people to know is that direct exchange is email. But it's a particular kind of email that has an added layer of security and trust and identity running behind the scenes. And Direct Trust is the nonprofit health industry alliance that's established and maintains the rules, standards, and policies associated with the operation of that security and trust and identity layer for direct exchange. And of course does that aligned with ONC and other health and human services policies, standards, and rules. So together we call these rules, standards, and policies security and trust framework. And Direct Trust uses this framework as the basis of a voluntary accreditation program for direct trust implementers who are known as trusted agents. They include health internet service providers, HISPs, CAs, certificate authorities, and registration authorities, RAs. And we also distribute what are known as digital certificates among accredited service providers so that direct messages can be more easily made secure and identity validated across different direct implementations. So in effect, direct trust is a policy and governance body that makes it possible for direct exchange to just work, and for direct users, that is subscribers and addressees, not to have to worry about their exchange partners' privacy and security practices. So let's go to the next slide. So this slide simply shows that there are components of the approach that direct trust is taking in collaboration with ONC and others to make direct exchange easy to use, affordable, and ubiquitous, as well as consistent. There are a set of policies. One of the most important one is our X.509 certificate policy, which was actually established in December of 2011, but which has been worked on consistently, and we're now up to version 1.3. With EHNAC as a partner, we launched an accreditation program for HISPs, CAs, and RAs in February of 2013. And as you'll hear, we have a number of accredited entities already, and a whole slew of organizations that are in the engagement process in the various stages of accredited. We're very proud that we received one of 2 ONC cooperative agreements awards in the end of March, and that collaboration is going extremely well. And then we have also started this month a Trust Anchor Bundle Distribution Service. And these components comprise an approach to the implementation of direct on a national basis, which we hope will avoid the necessity for organizations who are providers of direct services to have to engage in one-off negotiations or contracts with one another. If HISP A has to sign a legal agreement with HISP B and HISP C and HISP D, it starts to get very complicated, and it would make the network very inefficient, probably be a showstopper for direct if that has to happen. Next slide. We have about 65 members now. They are comprised of health information exchanges who are state-sponsored and are running HISPs. We have a number of HISPs, CAs. We've got a growing number of electronic health record companies who are under Stage 2 meaningful use, providing some aspect of direct implementation service to their customers. Some of them are HISPs, some of them are HISP CAs and RAs. We expect to see more of the electronic health record members joining Direct Trust as we get closer and closer to the beginning of Stage 2 meaningful use in 2014. Next slide, please. Under the Exemplar HIE Governance Entity Program, which is one of the cooperative agreement, is the name of the cooperative agreement program, we really have 3 goals that we're here to accomplish over the next year. Actually, we're down to 10 months. Most important is to advance the engagement of the industry in the EHNAC Direct Trust Voluntary Accreditation Program. And we're talking with a wider and wider group of participants in that every day. And then the second most important element of the cooperative agreement is to design and build out and operate at scale a Trust Anchor Bundle Distribution Service, which we call TABS, that transparently identifies the attributes of anchor certificates from accredited HISPs. And it distributes these anchors so that they will permit what is known as a technical trust relationship to occur and to grow at scale. Next slide, please. So I'm going to stop here, actually, in the interest of time, is simply reiterate that the approach that we're taking is to create a national direct network based on a clear, transparent accreditation program with audit, based on a security and trust framework which participants in the industry have voluntarily and in a consensual manner arrived at, and then using both of those to create a trust anchor bundle distribution service that allows HISPs to very easily know what other HISPs have done in terms of their standards that, with respect to privacy, security, and trust and identity. And I think I will go to the next slide. Let's go. Yeah. What we want to make sure it happens is that you avoid a message like this when you try to do direct exchange. That, for some reason the site's security certificate is not trusted, and therefore the exchange can't occur. What we'd like to have is that all of the HISPs and all the CAs are accredited, and therefore that kind of interruption in service never occurs. So I'm going to stop there, and I think Andy Heron is our next speaker. So Ron, if you'll just advance the slides and turn it over to Andy. Thank you.
Great. And David, thank you very much. I think between you and Claudia, you provided a tremendous perspective on ONC, what ONC is doing, what Direct Trust is doing, and now we can talk. Andy Heron is going to be talking about Cerner's experience in going through this. So Andy, we'll turn it over to you.
Very good. Thanks, Lee, and thanks everybody for giving me the opportunity to do this. Myself and one of my colleagues, Don Jorgensen from Imprive, are really here to help provide you a perspective from the field, if you will. And I'm going to do so from this perspective of Cerner, and I'll describe what we do here in just a minute. So advance the slide. So from a Cerner perspective, most of you may know us as an electronic health record organization. We actually have solutions which range from healthcare organizations of single doc practices to entire countries. We also touch pharmaceutical and medical device industries. And just generically for the field of healthcare as a whole, we have solutions that cover those areas and are licensed across around 9,000 facilities worldwide. So from a perspective and context of this presentation, we are a $2.7 billion company, so we fit into the EHNAC very large category. Don Jorgensen from Imprive will give you a perspective from a small organization. And also in context of this conversation specifically, Cerner is performing the roles of all three HISP, Certificate Authority, and Registration Authority as it relates to direct exchange and servicing our clients. And as a footnote, we are also accredited by EHNAC on all three of those roles. Go ahead and advance the slide. So Don and I are also wearing the hat of the perspective that we also are participants on the steering committee for the accreditation program itself. So we'll provide you, through this slide, a little bit of insight as to what the actual accreditation process looks like. And I'm going to cover this in an overview fashion. Certainly Ron is going to cover this later for you in a more detailed aspect, fill in the gaps. But this is just my perspective from a very large organization. So first off, there's an application. It's actually two steps. There's a pre-application and an application. Nothing out of the ordinary here. Pretty much contextual organization or contextual information about your organization, as well as seeking to understand what roles you are playing from a directed exchange standpoint. The next thing, which is really the meat of the accreditation process, is the self-assessment submittal. And essentially, we've collectively created a set of requirements that I think are topping over 200 requirements right now that cover all three of those roles, that cover various aspects of directed exchange. And for example, there's questions in there that ask us to provide information around privacy and confidentiality of information. There were some in there for technical performance, examples including our change management processes, how we do internet security, and there were also questions around resources, which include physical security, personnel, and those types of things. So it really spans both a technical but also a business and policy perspective. So putting that together is the meat of the accreditation program and helping people understand and shape how they are actually performing against these particular categories. And I'll talk a little bit more about that on the next slide. From there, after the self-assessment, there is the site visit itself. And in our case, this was completed in one day, as we have both our operations and our data center facilities and personnel relatively co-located. So an EHNAC auditor came out and spent some time with us for about a day, going through the self-assessment, asking questions, clarifying, and inspecting some of the responses and information that we provided. And then following that, essentially we get a site visit report from the auditor at EHNAC that lets us know how we did. And just prior to that, there is some back and forth conversations and clarifications that at least happen with us, and I'm guessing typically happen between the site visit and the report actually being issued to us, which essentially describes to us what has been found relative to the expectations of the accreditation criteria. And then in our case, obviously, as I mentioned before, we were successful and received an award for accreditation. Next slide. So as I took a step back and thought about what you all on the phone may wanted to know, I picked out two things, and again, Don is going to cover some additional topics, but one thing was effort itself, and certainly not something that should be underestimated. The first bullet, I referenced the certificate policy and then pointed to the fact that certificate practices statements, or CPS, needs to accompany that and be a part of performing the role of a certificate authority and registration authority. This in and of itself was a very large effort from a Cerner perspective. While we had processes and procedures in place, it was pulling them together in a coherent fashion and communicating those publicly to the rest of the industry, how we're doing what we're doing across the different aspects of what the certificate policy expects. So that was kind of a front-loaded effort, if you will, and actually made, when it came to the accreditation portion itself, we had a lot of the material and a lot of the processes and procedures pulled into place. But do not underestimate, especially if you are a CA, an RA, Certificate Authority and Registration Authority, the effort required to pull together those in a fashion that meets the expectations of this community. And then from an audit prep perspective, I would suggest, and what we did here that worked well, is that this is not a part-time role, if you will, for someone to go complete. To the extent you can, assign individuals that are focused on this, because it does take time and effort to pull this together. So as you can see here, I suggested creating kind of a core team, if you will. And it may be one person, or it may be shared across multiple people, but my point is, please don't underestimate and do create focus on this, as it does take some effort to pull this together. So then, to build upon that, what we learned, we thought this was a very healthy exercise. What the accreditation criterion really do is help you discover and think about all of the different aspects that are required as you offer these services to your respective customers and clients. As when you step back and think about it, sending information over the open internet is not something to be taken lightly. So we thought this was a healthy exercise to help us sharpen the saw, so to speak, on our processes and procedures, both from a technical and a administrative and policy perspective. And really what it did for us, in our case, is that it increased our confidence that we were doing the right things relative to what we as a community have expected, as well as it now allows us to look at others who have gone through this exact same process in the same light and be reassured and have the confidence that they have also thought about all these different types of aspects and put them into place in their respective organizations. Second bullet really is around the fact that Cerner, as we play the different roles that I mentioned earlier, we go through a fair amount of audits already. One of those key ones being the SSAE 16, or formerly known as the SAS 70 audit around our data centers. So that was very helpful in our specific case, because a lot of that same output was used to help provide the evidence and provide the responses to the criteria that this community expects. Third bullet, one thing you will notice if you are performing all three roles of a certificate authority, registration authority, and certificate authority, is that there is quite a bit of duplication when responding to the criterion for the audit. If you're performing those multiple roles, specifically there's about a 40 criterion overlap that really we provided identical responses to, but just be aware that there is some duplication there if you are performing all three roles. And lastly, what we recognize is that this certainly isn't a one and done. This is a continual process, and really it's kind of a mindset change as to how we operate and run our services collectively for our constituents and our clients in providing directed exchange and giving them the confidence that they can use this technology to complete the care coordination that they need to meet meaningful use as well as beyond. So I'm going to end on that and turn it back over to Lee. You can hear from Don.
Thank you, Andy. That was a terrific overview of your experience and what you've gone through, as well as the role clearly that you've played in being involved, as well as the steering committee, as well as the advisory committee, in developing a lot of the criteria here and providing ongoing feedback to the process as well as to the criteria. So thanks very much. Let me now turn it over to Don Jorgensen, who's going to talk about Impriva's experience as they've gone through the accreditation process as well. Don.
Thank you, and thank you, Andy, for the introduction. I am going to try and emphasize some of the considerations that a smaller organization might be unique, although as you'll see, a lot of them were shared by Cerner as well. I'm going to step back just a second and note that Impriva has been involved since way back when the security and privacy rule were about to become effective, and we piloted a product and stepped back and go, you know, before this is going to become ubiquitous as it needs to be. We're still not there, everybody, but it needs to be ubiquitous. We needed interoperability. We've been involved through EHNAC, we've been involved through InWin, and it seems like in terms of widespread deployment, there was some roadblock or log jam that would pop up. And it's been like peeling an onion each time. Each time we took another step, we saw what needed to be done next. And the Direct project recognized that and took strong steps to fill the gaps and reduce barriers. And kind of, it looked like we might actually be able to deploy health information networks to the masses. I was still a little skeptical, but it was a dramatically different approach, and we got involved. Let's note the level of collaboration from Direct project from the beginning right through to working with organizations and individuals like Andy and so on. It's just been amazing. So as we work through the specification steps, reference implementations, early adoption, which is in the early adoption stages, we began to build volume. Customers, state HIEs began to give feedback. We were peeling another onion, as it turns out. And we began to run into some things that were potential logjams, and in particular, trust and trust management, both by the provider and the HISP. And Direct Trust became a focus point for developing a framework, but we began to realize that there were details associated with level of assurance for the provider. Now, some of this has been touched on already, but we need to know who we're exchanging information with. So we need to, and we need to know the level of proofing. Even beyond that, we came to understand that it was going to be important to the community to know something about the HISPs themselves and the practices that they were, practices and procedures that they were implementing, and certificate authorities and registration authorities, and all of this. This began to point to accreditation, because without that, every state HIE, every provider was asking the same question over and over. What should I be worrying about? What's my liability? Who should I trust? And accreditation goes a long ways towards solving those. So we came, next step was we determined to move forward with it in PREVA. And while we signed up to be HISP, RA, and CA initially in our application, we had hoped to focus on what was key business for us, HISP and registration authority, and partner for the CA portion of it. As it turned out, the CA we chose to partner with wasn't ready to move through accreditation, so we elected to add CA. So we also tackled the HISP, RA, CA approach. And, next slide, please. Okay. And well, self-assessment, Andy introduced that, and as you see, my first statement there is we were not prepared. And this coming from somebody that was sitting on the direct steering committee, saw these things ahead of time, and still we weren't prepared. We weren't prepared for the level of effort that was going to be required in particular. And as we worked through the self-assessment, physical safeguards were in good shape, partly because of partnerships that we entered into. Technical safeguards, same thing, and it happened to be the area where we had a high level of internal expertise. And administrative safeguards, and I put that in quotes, the term safeguards, because I don't think I really thought of it as safeguards when it started out. HIPAA refers to it as safeguards, but it became clear that that was an area where it was going to take a lot of effort for us. And as a small company, there was relatively few of us that were wearing many hats, and so I'll echo what Andy said. This requires a great deal of effort, and be ready for it. And just an example, informal policy, it wasn't that the policies weren't there and the procedures weren't being followed. It's that they were written down in one place here, they were informal here, and EHNAC, and we saw it over and over again in the criteria and their guidance. What EHNAC is looking for is formal documentation, that. And now, a lot of work, yes, a lot of benefits from that for us. We felt like it was from this company that had a strong technical, strong product offering from a technical standpoint, security and privacy. Now we were being asked probing questions about detailed procedures, what were we going to do in this case, and even our responses led insight into areas that we needed to address going forward. The process has been very good for it. The feedback, pointing at the next steps we need to take has been very, very helpful. Next slide. So I guess we're hammering this home between Andy and I. It will take time and energy, and don't underestimate it. Read through those criteria, and don't do what I did, which was, yeah, we can do that, yeah, we do that, yeah. Think about it. Think it through ahead of time. You're going to have to get what's in your head out of your head and on paper and document those procedures, policies and procedures. Another point I'd like to make is choosing your technology partners carefully as a small company can make your task a lot easier. If you've got, if you're partnering with a data center that has the SAS 70 and PCI compliance in place, if they've got those policies and procedures in place, it's going to make your life a lot easier. Similarly, the partnerships that you establish as a HIS for your RA and CA relationships can help you avoid some really difficult criteria that you would have to meet otherwise. So at least look at the possibility of partnering RA and CA roles outside your organization if you're a small organization. And I wanted to wrap this up with talking about what we've been hearing particularly since the accreditation program has been announced and the governance grant has been announced. There's been a significant shift in reducing the confusion, or at least potentially reducing the confusion that organizations that are trying to build direct usage. We were getting asked questions before like, okay, we understand we can communicate amongst all of us, but if we want to talk to this HISP over here, or this state HIE, or this state, and we would explain to them, well, you really need to be concerned about some liability issues. You need to ask them questions about how they do proofing, and it went on and on. And usually they wouldn't do anything. Now we can say, you can arrange to have your providers have the HISP deploy a direct trust bundle that meets certain criteria. It's going to deal with accredited CAs, RAs, and HISPs. And if you recommend to them that they deploy that as a default, it's a policy that they can understand and implement. The HISPs can deploy and implement and support, and it's still flexible enough to allow the providers to make adjustments as necessary. So we've got a policy finally that we can say, hey, state HIE, this is what we recommend that you do and how you deal with this trust issue. Simple and clean. And I think, looks like my time's about up. I'll leave it at that. Thank you.
All right, Don, thanks very much. Appreciate it. I think that's a terrific perspective on a smaller organization going through the accreditation process, which did a great job of kind of pointing up what you went through and the issues. I think as well, just to add to one of the points that Don was making, if you want to see what the criteria looks like, you can go on to the website, the EHNAC.org website, and be able to take a look at the criteria today and see what that criteria is and what's included in it, which will at least give you a perspective as Don was talking about. So thanks very much, Don. We appreciate it. Let's go to Ron Moser, who's going to, and Ron, as I indicated when I introduced him, Ron is also a senior reviewer and auditor. Ron's done several of the audits on a number of these organizations for direct, along with myself. So I wanted Ron to give you a perspective about what you need to think about, what you need to be preparing for to go through a site review and audit. So Ron, let me turn it over to you.
Thank you, Lee. And I'm going to try to keep this fairly short. We have several questions. I want to make sure we can get to the questions as well. And some of this was already covered, the accreditation steps. Whenever a company wants to go after DTAP accreditation, like the other EHNAC programs, there are several steps involved. One is to identify your sites, and that may seem rather straightforward, but EHNAC and the auditors subject to the EHNAC Commission are very focused on identifying how information moves around, especially if you're handling protected health information. We need to know what sites handle that, view that, process that. Those need to be identified so that they can be reviewed. And then you complete your application. Again, as was already mentioned, there's a pre-app and there's an application where you just give basic company information, including identity of your sites. And you also determine which programs you are wanting to be accredited for, HISP, CA, and RA. And I'll just mention quick that during the beta process, these were actually combined, but we've now separated them out to make it more straightforward. So if you're going after CA accreditation, you'll receive criteria that is specific to CA, and you don't have to see all the other stuff. So there are 3 distinct programs, HISP, CA, and RA accreditation programs, and you can do one or multiple depending on the services you provide. And then as was mentioned, the big bulk of the work is preparing your self-assessments, and that's where you go through the criteria plus the additional information. Once you are accepted as a candidate, you'll receive a packet of information that has detailed information for each criteria that shows specifically what you need to include in your self-assessment to demonstrate compliance. And you have to put that whole package together, and EHNAC provides instructions on how to do that. And once that's all put together, you submit it. And I don't want to gloss over that too quickly, but it's already been mentioned. There's a lot of work involved in that. You really need to have a leader, and you need to have executive management support because it requires heavy-duty focus from the various entities in the organization that need to participate in this, especially compliance and IT, as well as some HR and others who need to provide input into this process. You then submit your self-assessment, and then once the site reviewer has had a chance to review the information, they'll work with you on scheduling your site visit or site visits. They will visit your sites, and again, typically it's 1 day per site. And then if there are any follow-up questions, those need to be addressed usually within 2 weeks, and then you'll receive notification of your accreditation award status. The programs, again, there are 3 programs, DTAP HISP, DTAP CA, and DTAP RA, and each program has 6 sections. And also each program, within each program, the first 5 sections are identical, and they cover the introduction to the candidate environment, and that's where you describe your sites and the functions of the various sites that you have. Section 2 is privacy and confidentiality, which really focuses in on the privacy aspects of HIPAA regulations, and technical performance, where you have requirements regarding how you control your environment and how you meet specific technical performance measurements, with a focus on having strong metrics in place for being able to truly measure and demonstrate that you're meeting various throughput or measurement type goals within your IT environment. Resources is a focus on your physical environment as well as your people, and that is making sure that you are staffed appropriately. We have a strong focus as we audit on customer satisfaction, and that is, we want to know that you don't have any single points of failure. You have appropriate cross-training involved, and that you are operating at facilities that truly meet the needs both from a security standpoint and from a capacity standpoint. And then security, which is a big focus of that, is straight from the HIPAA security regulations. Section 6 is then unique within each program, and if you're doing the HISP program, there are 14 specific HISP criteria. If you're doing CA, there are 64 specific CA criteria, and RA, 56 specific RA criteria. As I think Andy mentioned, a significant part of this accreditation, the DTAP programs, especially for CA and RA, is putting together your certificate practices statement, which is based on direct project certificate policy. So a really big part of it is having your certificate practices statement put together, all the various sections, and then these criteria actually point at those sections to make sure you've completed them appropriately. So we provide instructions on how to do these things, and that's the focus of these various programs. Scoring is done as is with all the other EHNAC programs. We score each individual criterion either a 0, a 0.5, or a 1, depending on the level to which it was met. And you must have an overall minimum of 85% to earn accreditation. So if there are 160, well, I'm going to give myself too hard of a math challenge here. If there are 100 criteria, you have to get at least 85 of them correct. You get the idea. But in addition to meeting 85%, all criteria that are designated mandatory must be met. So even if you got a 95%, but you missed one criteria that's designated mandatory, you would fail accreditation. So all of the mandatory have to be met, and the HIP, CA, and RA specific sections of the criteria, most of those criteria are mandatory. So it's very important that all of those are met. Some other notes are just in general, important things to know. An organization, again, may apply for 1, 2, or 3 of the programs. If multiple programs are pursued, common responses to common criteria can be cross-referenced. So as I mentioned, each of the 3 programs have common sections 1 through 5. If indeed the response is the same between programs, you can simply make a note of that. You can complete it for one program and then specify that the response in the other program is the same, and you don't have to reiterate the whole thing. But we do expect you to tell us that it's the same. We won't just assume that. Also, between the CA and RA, the unique criteria between CA and RA, many of those are very similar. And in a lot of cases, you can just specify that the answer is the same in the CA program as it is in the RA, and you don't have to reiterate it all, if indeed that's the case. If multiple programs are pursued, and basically that's just what I said, common responses to common criteria can be cross-referenced. If no PHI is handled by your organization, if you're a CA and or an RA and you handle no protected health information at all, then you need to look at the PHI-related criteria and address them as you would for protected, personally, I can't say it, for personal information protection, because that is the level you would need to address it at. You wouldn't be under the HIPAA requirements if you're not handling PHI, but you still need to know that the personally identifiable information is appropriately controlled, and you would answer them in that context. We probably, in some future release, will build the CA and RA programs to address non-PHI criteria a bit differently, but at this point, if it's specific to PHI and you don't handle it, then you address it based on personally identifiable information. Finally, EHNAC does provide detailed instructions, and it's very important that those are read and followed. It's a lot of times hard to get people to read instructions. People want to jump right in and do it, but it really does save a lot of time in the long run if those are read. And also, we are always available to help further explain how to address the various issues. With that, Lee, I believe I'll turn it back over to you, and we can go through some of the questions. I think, Lee, you might already have some questions, and I can read some to you as well.
Okay, terrific. Thank you, Ron, and thanks for that perspective. I think the other point that I would make on yours, Ron, is also the fact that the process of going through the site review and site audit is really very consultative as well. So as we're working with organizations and going out on site reviews and site audits, the intent is to help organizations to, in fact, raise the bar and position themselves to provide either additional services or both. So it's a very consultative process, and not just going out with a checklist to determine whether or not the organization meets the specific criteria or the types of evidence that we're looking for. So I just wanted to emphasize the consultative nature of the process as well. So this next slide basically says really get ready for the ride over this next year. I think we've got a lot to do to get ready and to work together to achieve compliance. So before I get into the questions, I'll just reiterate, if you do have a question, please down the bottom of your screen type in the question, and we will try to get to as many of the questions as we possibly can in the remaining 25 minutes that we have for the webinar. So let me start off, Ron, with the first question while you're teeing up the questions to send to me. So the first question, and David and Claudia, I'm going to ask you to respond. Why would a HISP want to become accredited? Are there specific examples or situations in which subscribers to a HISP might benefit from non-accreditation? So David, you might have a thought. David and Claudia, you might have a perspective on this.
Claudia, I'll let you go first.
Well, you know, our audacious goal is that a provider could refer a patient and without thinking twice, send along their information electronically, confident that it would be secure, confident it would get to the right destination, and not caring an ounce about what vendor the destination is using. So this picture of a future of ubiquitous directed exchange to support care coordination, it needs us to think of ways to achieve vendor-to-vendor exchange that don't rely on everyone negotiating agreements one by one, but allow for us to agree on the requirements, put them into place, and agree that if those requirements are in place, we're going to allow for vendor-to-vendor exchange to occur. So to achieve this very simple vision, we need a scalable way to create trust among vendors based on a common set of requirements. So I think that's why I'm not going to argue the con side. I'm sure there are examples, but I think we're looking for rapid change, and this is how we get there.
Yeah,
okay,
this is David. Claudia, that's very well stated. I'm not sure I could do any better with that. I think if I have someone else's direct email address, I simply want to enter it into my application, whether that's a web portal or a smartphone or my EHR, and I want it to get there. If we don't have an accreditation system with audit that sets this baseline and allows the partners who are transferring and transporting the messages on our behalf to know what the security and trust and identity practices are of any endpoint, then the only alternative is that they would have to negotiate one-on-one with one another. By the time you have 28 contracts of that kind, by the time you have 28 HISPs, you have 327 contracts to maintain. And I think that's just, it's just not going to work. I would say that if there is a HISP somewhere with, 50 or 70 addressees or subscribers, and they know they're only going to have to communicate ever with one other HISP that has, a limited number of subscribers, that might be a situation in which they would sort of opt to be off the grid and use the technology without needing to communicate to the network. But I think those are going to be few and far between.
Thanks, David, and thank you, Claudia. Very good perspectives. A couple of questions have come in. Let me try to go through some of them in the order that they have. First of all, for people asking, will the slides be available? The answer is yes, and I'll tell you in a second. Along with the entire session is being recorded, so if you know of people that haven't had a chance to review it or participate on the webinar, yes, they will be able to review it as well. The session, as well as the slides, will be available certainly on the EHNAC.org website as well as directtrust.org website, and you can at least go to both of those and get those. and get the recordings will be probably available within the next couple of days, but certainly the presentations will be available immediately. So hopefully that answers the question on where to get them and the fact that it will be available. The next question is LOA 3 a requirement or a recommendation? Ron, do you want to, can you address that?
I can address it in part, but I think I probably will turn it over to someone else. And actually, just to get it answered in the best possible way, Andy, would you be willing to take that?
Sure. LOA 3, from a direct trust standpoint, where we have defined what level of assurance 3 means, which were based upon NIST 800-63, as well as several other existing standards out there today, is the current requirement for provider-to-provider exchange and the expectation around that. Patient certainly is currently being debated across the industry, and the direct trust community will provide guidance on that upon determination.
Thank you.
And can I just, Claudia, I'll just jump in to say that the guidelines which we released, which represented the community kind of assessment of minimum, did require LOA 3 level, more or less, for the authentication of the end users. There is a little bit of difficulty because some people use the FBCA categories and some people use the NIST categories, and there's not exact matching between them. So that's one thing ONC is trying to work on, is have a better mapping so everyone's talking the same language, so you don't have federal partners talking FBCA and other people talking NIST. So that's just a sidebar, but something we need to work on.
Yeah, and this is David. Just as a point of information, if you go to our website and download our certificate policy, version 1.2, we have 4 levels of assurance that we've defined in direct trust. And in the tables, we map them to FBCA, NIST, and Chemterra. So it's a really nice resource there within the certificate policy. I think it's section 3.2.3.1. And it illustrates exactly the point that Claudia is making, is that these levels of assurance and the documentation for identity verification using them don't quite match. So we've done the best we could to sort of bring that out and to show the differences. I would also add that it's very likely that one of our trust anchor bundles in the not too distant future will be for federal agencies, and it's very likely that the minimum level of assurance there will be FBCA medium, which is just a notch higher than this level 3.
Great, thanks.
So this is Don. I thought I'd just mention as a follow-up there that trust bundle at the level that Claudia mentioned earlier was going to be in her slides, NIST level 3 with FBCA basic process is likely to be the baseline trust bundle that most organizations would deploy as a default, and then build off of that.
And I also just want to, this is Claudia, one thing that's so fabulous, I think, about direct is that what we're talking about is what the technology needs to adopt as basic security requirements. But remember that and we want to make it easy for the doc, but the underlying kind of requirement is that I get to decide when I want to send to you. So yes, I want it all to be secure. I want the requirements to be in place. But unlike some other health information exchange models where we're giving up our data, we're allowing for it to be used, right? The requirements can be quite slim because we're just trying to protect the information, understanding that the 2 end users are making decisions about when and where they want to share it. And so it's just an important context to put around all of this work, I think.
Good perspective, Claudia. Thank you. Great. Okay. Don, the next question is for you. It's a small company. How long did it take you to go through the accreditation process?
Well, the core part of the process was about 3 or 4 weeks, partly because we unwisely didn't start early enough. So we were hurrying, and I'll note that we're at the tail end of that process right now, and it got delayed a bit because our point person, and this is the danger of a small company, our point person had open heart surgery, or bypass surgery. So we stepped back, and I would like to note that 2 things. The EHNAC was very cooperative in working with us around those issues that created. And I didn't say before, but that consultative feature of helping us understand what we needed to do to deal with things in that situation was great. So anyway, I think in a normal situation, given time to remediate, and given somebody taking the point as everybody has suggested here, you should allocate a month, and you should allocate probably a full man-month of somebody's time to get it done. And that's if you've got partners that are handling major data center issues.
Thanks, Don. That's a good perspective. I think also to clarify for people, if you go through and apply and submit an application, and you are a candidate for the accreditation process, organizations have a year to go through the entire process from start to finish. Within 8 months, the self-assessment portion has to be submitted within that maximum period of time of 8 months, therefore allowing up to the 4 months, the additional 4 months for the site review to be scheduled, the review of all the documentation, etc., during that period of time. Many of the organizations will probably go through the process much faster than that, but that is the maximum amount of time that organizations have to go through the accreditation cycle. So hopefully that helps to explain it. The organizations that worked with us on the beta, we started the beta process. The beta process basically is all of the same criteria that organizations went with. These betas basically were providing us ongoing feedback and on both the criteria and the process during the period from January through basically the end of April, beginning of May, that the organizations have gone through and went through so it was a very compressed period of time. We were looking to get feedback on the criteria and the process, which we did. And so those organizations went through and have gone through the whole accreditation cycle. So the next question that we received had to do with the pricing for EHNAC accreditation and for the direct trust. So for our DTAP accreditation model, it's based upon a tiered pricing model, and we've developed 6 tiers for pricing, starting with very small and going to very large. The very small category is for less than $3 million in revenue on an annual basis. And so the annual fee for that particular tier is $2,500 annually, and then the site visit is $4,500 per site for that particular tier. And it goes up to as I said, the very large organizations, which is greater than $75 million in revenue. And so the annual fee for an organization in that tier would be $20,000, and then the per site fee for 2013 is $7,500 per site. So that gives you an idea of the various ranges we've tried to keep for small organizations. And as I went through that, it's about approximately $7,000. We did not want to make that tier, or any of the tiers for that matter, cost prohibitive. We don't want to create an obstacle there, so we want to encourage as many organizations as possible to go through and apply for the accreditation process. So for 2013, those are the levels and the tiers that are there. I would suggest to you to go to the accreditation guidelines under EHNAC.org, which reviews all the various pricing tiers and the pricing models so that you can get a feel for and understand what's incorporated in them. Those accreditation guidelines go through really the process, the fees, and the guidelines. That will be helpful to you. And again, if you have any questions at all, certainly you can email us and or call us with any additional questions, and we'll be happy to get back to you with any information that you need to go through the process. So hopefully that answers that particular question. The next question, I'm going to, David, Andy, I'm going to ask you to talk about, can you explain the term trust bundles? What does that actually mean?
Yeah, I'll try and give it a try. A trust bundle is a group of trust anchors. And a trust anchor is a signing digital certificate that matches with other certificates. The way this works is very similar to the way that your web browser works when you go to a secure website. On your browser, there are anchor certificates, approximately 50 of them, and those certificates match with a website certificate when you go to your bank or you go to LLB or Amazon.com. So there's this exchange of certificates that do two things. One, it encrypts the session, and it also authenticates the website so the website isn't spoofed. In this analogy, Direct Trust is acting like a web browser. We are holding trust anchors from accredited parties, and we are making them available so that they are used to facilitate not e-commerce transactions, but e-health email transactions.
Great. Thank you, David. Andy, anything else that you would add?
Yeah, I would just add that the value to me as a HISP operator is twofold. One is it gives me the potential to have a place I know I can be confident in to accurately retrieve that information to include in my implementation to allow trust to occur with that separate entity. And then secondly, it provides a convenient mechanism for me to potentially, instead of on a one-by-one basis grabbing those, being able to collectively grab a set of anchors to add to my trust community that all represent a single expectation or a set of requirements.
Yeah, there's one other thing that needs to be said about trust anchors is that in the definition of technical trust between HISP A and HISP B, which we know is actually trust between the subscriber or addressee at HISP A and the subscriber or addressee at HISP B, that technical trust is defined as each HISP having the other's trust anchors in its trust store. So there literally is no exchange unless the trust anchor of HISP A is in the trust store of HISP B and the trust anchor of trust B is in the store of HISP A. So that's the role of these trust anchors is very important, and as Andy pointed out, bundling them makes it really convenient and inexpensive for the parties to not only know who's trustworthy, but to go get their trusting.
And lastly, one thing I'll add on to David's comment there is that the other value proposition for this too is that there is, at least the way we build it within our community, there's the ability to go auto-retrieve that information so that I don't have to manually think about that. So if there's new trust anchors or ones that come in and out of the community, if I collectively decide that whatever is represented by that trust bundle is acceptable by my users, or they decide that, then it automatically keeps me up to date.
Great. Thank you very much. So, Ron, this question is for you. if you use a vendor to supply the actual technology, while the organization offering the service doesn't supply the technology, what accreditation should an organization seek?
Okay, well, I think it's probably, it seems to me that would be if you're a HISP. I'm trying to think of how it could be otherwise. Certainly a HISP may be using a third party to process transactions at a data center. And I suppose a CA and RA have an outsourced data center as well to be able to house the certificates, especially a CA, and to do some of the work they do. But I think it really comes down to the organization. They've got to determine what services do they want to offer, even if they're outsourcing some of the work required to do it or some of the aspects required to do it. Probably the answer is any of the three. What do you want to be? You want to be a HISP, a CA, or an RA? And you obviously need to know what's involved with whatever it is you're pursuing. But yes, you can outsource different aspects of that. If you're a HISP, you may have a data center and some of your technology outsourced, but those outsourcing it doesn't remove the scrutiny of how that's handled from the EHNAC accreditation. The self-assessment will have to include how that outsourcer does the work that they do, and part of the site review will be interviewing entities within that outsourced organization. I think there's another important thing that comes into play, and that is if you're a HISP, it's important that, and I think they touched on this earlier, that the CA and the RA you use are either EHNAC, Direct Project EHNAC accredited as well, or that they are certified or accredited through an acceptable entity.
Good, thank you. Okay, so let me, I think we've got time for one more question. What is, and Don, Andy, let me turn to you for this. What's the importance of including the Direct Trust OID in your own certificate policy? Don, you want to take that?
Okay, so when they say in their own certificate policy, so we do it that way because it's a particularly convenient way and avoids having to map. In fact, our certificates then just reference in each certificate that direct CP OID. It needs to be referenced in order for for everybody to understand what policies the certificate was issued under. So one way or another, it needs to be available and referenced. Andy, you may be able to elaborate too.
Andy, anything? Any perspective?
I don't think to elaborate on Don there, except to say that, yeah, it's just a standard way underneath public key infrastructure, existing PKI best practices that you attest to or you indicate what policy this particular certificate was issued under. And in this case, and in this context of this conversation, we're talking about direct trust.
Great. Thank you both. All right. Thank you, and thank you to everyone who has participated for your questions, your participation in the webinar, and we hope that the information that we provided will help you as you're going through and looking at direct and how direct and direct protocol and how you'll be implementing it, and hopefully going through and applying for the accreditation. If you are certainly qualified to go through that process, we would certainly like to have you go through, as Claudia did a great job of presenting and the perspective here, to go through, and you can go on to the directtrust.org or EHNAC.org website to not only apply for EHNAC.org for the application process, but also the presentation as well as the recorded version of the webinar will be available as well in the next couple of days. So thank you all for participating, and I also want to thank my panel for excellent presentations and for answering the questions and providing terrific context for all of you. So Claudia Williams from ONC, David Kibbe from Direct Trust, Andy Hareen from Cerner, Don Jorgensen from Impriva, and Ron Moser from EHNAC and Moser House Consulting. Thank you all, and look forward to some future webinars that we'll be having as well on this topic and other topics as well. Have a great rest of the week. Thank you all. Take care.